Good afternoon, everyone. Thank you so much, Diabetes India, and giving the opportunity to talk in front of us. So my talk is about the managing obesity and diabetes in primary care. So the thing is, we talk about the primary care, and we have the least time to talk about primary care, but it is the most important one to understand. And so I would be talking on the practical approach for primary care physicians here. So being about talking about the diabesity, it is diabetes plus obesity, a term describing a strong correlation between obesity and type 2 diabetes. And this obesity is a primary driven for the insulin resistance leading to development of diabetes, and it's a global public health crisis leading to a lot of risk factors of diabetes and consequences of diabetes and obesity is on cardiovascular, liver, kidney, and leading to micro and macrovascular complications. It is a global health challenges, and statistics talks a lot about this. Particularly in India also, if we talk, almost 5% of the contribution of the obesity is to the Indian population. If we talk about diabetes, we are already reached 212 millions individuals who are already affected here. So the statistics underscores the critical need of effective management and preventive strategies in primary care to address the growing burden of diabetes here. So now why primary care matters? Because the first point of contact of these patients are the primary care physicians. Early the detection and the better is the complication which we can treat. Comprehensive and continuous care is required where regular follow-ups are taken by the patients to their healthcare professions who are at the primary care. India is driven by the cultural sense, and our patients are more connected towards their primary care physicians, and that is my whole talk is about today. So patient education and improving is very important, and that can lead just by giving and creating awareness for the family physician people here. And it will help us to coordinate for these patients with their primary care physicians here. Addressing the health disparities, community based programs can help early detection and target intervention. This all will strengthen the obesity and diabetes management in the primary care, which reduces the burden of diabetes here. So the objectives is like a model of the link leading to diabetes plus obesity is related to insulin. Obesity, where increased adipose mass, and diabetes, where increased plasma glucose, are linked by common dependence of insulin action and secretion in peripheral tissues and the brain here. So ultimately, the impact of excess weight on diabetes progression and complication can lead to metabolic syndrome. There is a link between the obesity driven insulin resistance and excessive visceral fat leads to chronic inflammation and impaired insulin signaling as well. The second link is with the beta cell dysfunction. The third one, if we talk, is about the adipokine imbalances. And neurohormonal activation also leads to metabolic syndrome here. And the main key contributor factors is for the metabolic syndrome is insulin resistance, endothelial dysfunction, visceral adiposity, and because of generic and the environmental factors which is leading to systemic low grade inflammation is because of the excess calorie intake and insufficient physical activities. So the main key strategies is early detection and diagnosis, intervening wherever it is required. So we detect early, then we can treat it better. Primary care physicians are closely associated with their patient because of a cultural driven, and they have a strong hold in the local areas. So the honest responses come from the physicians to the from the patients to the physicians about their lifestyle, which can really be a big insightful for their factors which can lead to metabolic syndrome here. We check for the vitals, the waist circumference. Obesity assessment can be done at the level of BMI, also with the waist circumference. If possible, we can take the body composition analysis, which can give us fat percentage, muscle mass, and visceral fat as well. Additional risk factors can be included to look out for the liver, lipid profiles, and the key takeaway from this slide is like early screening in the primary care can help detect obesity and diabetes early, prevent complication, and improve patient outcomes as well. A together and a holistic approach is required for these patients. A personalized diet, exercises matters a lot. If we go for the DASH diet, it is helpful. We focus on protein, fiber, and healthy fats as well. We can also promote for reducing processed food and sugary drinks, and aim for 7 to 10% of weight loss in 6 months to 10 months, which has improved and reversed the metabolic parameters. And these are the lot of publications which has come across this. So fit principle is something which we follow. At least motivate the patient for 5 days a week. That is a frequency, intensity, type, and time. We can start with moderate exercises, reach to the vigorous exercises. Type can be a combination of aerobic and resistant training. And the time is about 150 to 300 minutes of moderate exercises can be really helpful. I want to just take 30 seconds on this slide because it's a very important one, and that is about the cognitive behavioral therapy, which helps manage emotional eating in primary care. Being consultants, we talk to patient, but we cannot give much of time to the patient. So physicians who are at the primary centers can really help us with that by recognizing the behavioral therapy of the patient. Example, I had a stressful day, I deserve a sweet treat. We can help out with the thought of a patient to the behavioral pattern relating to the emotion pattern. Developing awareness is by using food diaries and hunger tracking to differentiate physical versus emotional eating. Practicing the mindful eating, slowing down the way we eat, savoring the food, enjoy the food, getting distracted from the TVs and the screens can really helpful for these patients. It is also replacing negative thoughts with realistic and positive alternatives. If I have to talk an example on it, eating junk food won't reduce my stress, but walking some steps can really be helpful. Behavioral strategies can be coping without the food intake. We can encourage the patients to not opt for food and the delivery apps which are there, but opt for some meditation part, exercise part, and social activities. Teaching urge of serving, delaying the management of food hungers can really help these patients out. So smart goals, that is like specific, measurable, attainable, relevant, and timely goals can be opted for this patient, which can really help them a lot. And of course, we can use the help of the wearable technologies which are available. We all know about the pharmacotherapy. I don't want to go in details of it, but the conclusion and the takeaway from my talk on managing diabetes in primary care is by creating awareness. Early intervention is the key. Multidisciplinary approach works the best for this. Nutrition and lifestyle change is the first choice, followed by medication. And wherever it is required, intervention can be done. And empowering our patients through the education and awareness. The global threat to us is not by any virus or bacteria, but the global threat is by the obesity. The patients which are actually sitting in our OPD in waiting room, we just have to tap them on the right time so we can treat them early and we have a good results here. Thank you so much for your patience listening once again.